Hello, everybody. Thank you for joining us on this webinar today. I'm Dr. Jen Lee. I'm a transplant nephrologist at Westmead Hospital in Sydney. It's my pleasure to introduce our panelists and moderators today, our speakers today. So we have two papers published in Transplantation. It's currently online first, and they're both retrospective studies looking through the Center for International Blood and Bone Marrow Transplant Research at CIBMTR, and also the Organ Procurement and Transplant Network, OPTN, focusing on risk factors for solid organ graft failure and death in solid organ transplant recipients undergoing hematopoietic cell transplantation. And the second paper is also the other way around, where the risk factors for solid organ graft failure and death in hematopoietic cell transplantation recipients undergoing solid organ transplantation. I will introduce my co-moderator today, Dr. Shweta Anjan, who's a transplant ID physician at the University of Miami Transplant Institute. She's a current editorial fellow for the Transplantation Journal as well. Shweta, over to you.
Thanks, John. I did want to point out before we start that the Transplantation Journal Editorial Fellowship is currently accepting applications for next year. So if you're interested, you should definitely apply. Thank you for inviting me to moderate this excellent session. And we are actually joined today by three of the authors on these publications, Dr. Rachel Phalen, Dr. Meera Gupta, and Dr. Michelle Schoettler. So Dr. Phalen is a pediatric hematologist specializing in blood and marrow transplantation at Children's Wisconsin. Her research area of focus is in late effects and survivorship care following childhood cancer and blood and marrow transplant. Dr. Meera Gupta, our second speaker, is an abdominal transplant surgeon at Duke University with interest in clinical and translational research in the areas of kidney and liver transplantation and solid organ transplant outcomes among patients with hematopoietic cell transplantation, cancer outcomes, and disparities in access to transplantation. She's a principal investigator on an NIH-funded clinical pilot study examining mineral bone disease biomarkers after living kidney donation and living donor kidney transplantation. She's an associate professor of surgery and the surgical director of the Living Donor Kidney Transplant Program at Duke Transplant Center. Our third speaker today, also an author on both the papers, is Dr. Michelle Schoettler, who is a clinical and translational researcher and pediatric hematology oncology physician specializing in blood and marrow transplantation at Emory University and Children's Healthcare of Atlanta. She holds the Dan Amos Jr. Faculty Endowed Chair and serves as assistant professor of pediatrics. She is a principal investigator on multiple clinical trials and biomarker studies, and her research centers on transplant-associated thrombotic microangiopathy, endothelial injury, and complement activation in pediatric hematopoietic cell transplantation. So we truly are joined by some of the experts in this area that we have chosen today. So before we start off, my question for all our speakers is, what really inspired you to take on these topics? It is not a common area of research, but a very important one now.
Thank you, Dr. Anjan. I'll take this one. So this was a long time coming as a provider seeing patients for transplant evaluation in clinic, whether it's for kidney or liver transplant. We take a great deal of time understanding the patient's past medical and surgical history and how that may impact their care and their outcomes should we do a solid organ. So for the most part, unless under an approved protocol, active malignancy has been a contraindication to solid organ transplant. And when a patient presents to us with a history of malignancy, we have to assess the risk of recurrence alone and then also in the face of immunosuppression. So every so often, we will see a patient who had a prior hematologic malignancy and, say, an allogeneic bone marrow transplant. This creates an additional layer of immunologic complexity to their care, leading us to search for guidance in the literature, which at the time was non-existent. And these patients want to understand their risks, and providers want to know if the outcomes are acceptable and comparable to the general population of solid organ patients. So what has our current practice been? Well, we have had small case series reviews and single center experiences to rely upon to inform our practice. And as a result, transplant centers have had non-standard waiting or surveillance periods to ensure that the patient with this prior malignancy and hematopoietic cell transplant is stable and suitable. And we work closely with hematology. But it's largely unclear and not standard. And then finally, what we're noticing over time is that bone marrow, blood, and stem cell transplantation has come such a long way that we are starting to see patients live longer, again, with medical comorbidities and more likely to have end organ dysfunction. So that sort of motivated us to do this project. We sought out to understand the intricate complexities of these patients with both a hematopoietic cell transplant and solid organ transplant, their challenges, and then understand their solid organ outcomes.
Thank you, Meera. Can you describe in some more detail, your study design and everything that led up to the final product that has been published?
Sure. So when we created our study, we sought out for the data, and the data was provided by two national registries, the CIBMTR and UNOS. UNOS is the Solid Organ Registry, and CIBMTR is the Hematopoietic Cell Transplant Registry. Identification of these patients was not straightforward. We had to put together a platform where we could merge both registry and identify these patients who've had sequential transplants. And one can imagine that's a huge task, but we were able to do it over time. And once these patients were identified, we had to determine which one of these transplants occurred first, and then how did that impact their course, and ultimately how their solid organ transplant did, whether the hematopoietic cell transplant was performed first, or if they required a hematopoietic cell transplant afterwards.
Yeah, and the CIBMTR, just to for those that are not as familiar with the bone marrow transplant field, is a great registry that collects data on all transplant recipients, some basic data, and then there's a research component that people can consent to, and that gives additional data about transplant outcomes and complications that can happen. And so it's a really rich data set. And this is the first time that these two data sets were merged together to be able to answer a question like this.
Michelle, do you mind if I ask, in terms of the CIBMTR, sorry, the level of data that you get, like the preconditioning, the chemotherapy agents, all leading up to this, and all the complications, is it all, how granular is the data?
Yeah, that's a great question. So the CIBMTR has two different levels of data that they collect. There's data that's collected on everyone, and that is your transplant indication, some of the data that you're talking about. What do we give to you prior to transplant? Are you alive or are you dead? And then there are detailed forms that collect lots of information, specific information about infections, about graft versus host disease, many different details. And there's some randomness to how those patients are selected and some system level ways to select those patients. So not everybody has all of the detailed information, but everybody does have alive and death status, a lot of the things that we'll be talking about today.
And a key question, I guess, that impacts the graft and patient survival really is the degree of matching. So you've got matching between the for the bone marrow transplant, then you've got matching for the kidney transplant. How can you reconcile that, or is that something that needs to be considered in the future?
Yeah, I think it's a key limitation that we'll talk about later. So we do have HLA matching. So from the bone marrow transplant perspective, we know the match of the recipient and the donor. What the data that we don't have is for the living and the deceased donors from the solid organ transplant, and maybe Meera can speak more to this. We don't know if that donor is the same as the bone marrow transplant donor. And we do believe that very likely influences outcomes. Patients with the same solid organ and bone marrow transplant donor probably do better. There's and can come off immune suppression. There are lots of different things, but we don't know that in this study.
So just in real world practice, how do you manage that? So you've got an allogeneic kidney transplant, allogeneic bone marrow transplant. Do you guys try to match it, or do you just mainly do the matching for the bone marrow side and hope that the kidney one is okay as well?
So I can tackle the solid organ matching. We do a HLA flow cross match for all of our solid organs, and we send HLA prior to listing, so we know what their antibody profile is prior to even getting them on the waiting list. And then we perform serial HLAs every 3 months to reprofile them to make sure they don't have any sensitizing events. If possible, we do try to get previous donor samples if they've been stored somewhere, especially if they had had their prior transplant at the same center. And then we can also send donor-specific antibody and also determine if those antibodies are more active or not, depending on when we draw them. But largely, we will cross-match a recipient to a potential donor, but we will also look at their historical HLAs to see what antibodies had, MFIs of over our cutoff to determine whether or not that's clinically significant and whether or not we would proceed with the transplant. So that's the best we can do. When it comes to UNOS data, we do have HLA, but it's not very detailed. We know the degree of matching, but we don't know the specific class 1s, class 2s, and alleles. So it's not as straightforward. One thing that's nice about the CIBMTR data set is they have more detailed information about the donor, especially if they were living donors, if they were living related, etc. And the UNOS data does as well. It's just not as detailed, and we can't confirm or deny whether or not the donor is one and the same for both transplants.
And I'll just add,
So
I'll just
that's
hop in.
for kidney transplant. Sorry, yep.
Oh yeah. So in clinical practice as well, it's just there's so many difficulties about this, right? Oftentimes we can't predict who is going to need a solid organ transplant in the future. Somebody could have acute kidney injury, somebody could be on dialysis for a short period of time and never actually need a kidney transplant, or they may be on long-term calcineurin inhibitor immunosuppression and gradually develop chronic kidney disease and need to be, deemed potentially eligible for a solid organ transplant. So it's hard for us to choose our donor in terms of stem cell transplant donor, predicting that they may need some type of solid organ donor, and we don't know who that person's going to be. And then also vice versa. I've taken care of patients personally who have had solid organ transplants and then needed a stem cell transplant afterwards. And we need to match their HLA to their immune system, and oftentimes that doesn't match to their solid organ. So it's a very difficult scenario. I would say it'd be very lucky if it did match to their solid organ, but yeah. And then managing the immunosuppression afterwards is always a challenge.
Yeah, fantastic.
Yeah, I was actually going to say, I think the timing between those two transplants is so, they're so far apart that it's hard to predict who will need the transplant, first of all, and how you could best match them. Lots of moving parts, and especially more so because it's a retrospective study. You only realize what you need when you're looking into the data. Which is a good segue into for our speakers. Maybe you can tell us, for the solid organ patients undergoing the hematopoietic cell transplant, can you go over some of the study or the cohort results? And then later Jen will be reviewing the other paper, and maybe we can see how nuanced these two different groups are. Because clearly even the sequence of transplant seems to make a difference in the outcomes.
Yeah, I think so. So to be clear, I'm going to be talking about the patients that first get a solid organ transplant and then later need hematopoietic cell or bone marrow cell transplant. So overall, as Meera said, the data sets identified a fair number of patients. The data were cleaned, so we removed duplicates, we removed patients with key missing data like survival data. And at the end, there were 83 patients that first had a solid organ transplant and then a bone marrow transplant. And it's important to note the cohort was relatively heterogeneous. So when you think about the solid organ transplants that they had first, the most common or the highest proportion was a kidney transplant. So about just over half of the cohort had a kidney transplant. Liver was the next most common, so 26 of those 83. And then thoracic was pretty rare. So there were 15, and that combined heart transplants and lung transplants. And when you looked by solid organ transplant type, there weren't really meaningful differences in the age at the time that they got their solid organ transplant, differences in race or sex or the year that they had their solid organ transplant. But there was a difference, as you said and pointed out, in terms of timing. And so the thoracic solid organ transplant recipients proceeded to BMT a median of just over a year, so 13 months from their thoracic solid organ transplant. And that was different than the liver transplant recipients, which was a difference in 41 months. And then the renal transplant recipients were 93.8 months. So there were differences in terms of when they proceeded to that bone marrow transplant. There were also some differences in the proportion of living and deceased donors. As would be expected, all of the thoracic organ transplants patients received a deceased donor, and about half of the renal transplant recipients received a living donor, just to highlight some of the differences there. When you then look at, well, how different were their transplant characteristics? It was fairly heterogeneous there too. So about half of the cohort received an autologous transplant, so from themselves, and about half received an allogeneic transplant. And then among those who received an allo, there was really quite a lot of variation in terms of the donor, related or unrelated, the stem cell matching, there was matching and mismatched. And then the source itself, it was largely from the peripheral blood stem cells, but there were some other stem cell sources as well. And I highlight this because it will become important as we discuss outcomes. We as a field appreciate that autologous transplant recipients in general do better. They have less death and complications related to the transplant process itself. So we'll talk about that and how we separated those cohorts to better understand that. And in the bone marrow transplant setting, similar to as Meera was describing, we have all of these things that we look at when we think about somebody's candidacy. And one of the things that we have several different calculators that we quantify how many comorbidities, how sick are you coming into transplant? And when we looked at these patients, again, perhaps not unsurprisingly, they had really high comorbidity scores, suggesting that they had lots of different problems in addition to just the solid organ transplant that we know about. And we know that that is an independent predictor for poor outcomes for death post-transplant. So we also think about, because it's really relevant to organ function, the medications that we give to prevent graft versus host disease, and there really weren't meaningful differences by organ transplant type in the graft versus host disease prophylaxis approaches either. So that's kind of who the patients were. In terms of the indications for transplant, most patients had a malignant disease, so about 84% of them, and most of that malignant disease were types of leukemias and lymphomas, some plasma cell disorders as well. And we sort of highlighted the missingness of we don't know about the donor relationship from the organ and the bone marrow transplant. So that's kind of who the patients were and a bit about their transplant. Any questions about that?
No, that was actually very comprehensive. Thank you. Overall, do you also want to add on comments about their outcomes or their graft survival? I was really curious because you would think if a patient gets a solid organ and a stem cell transplant that their rates or risks of infection would be much higher, but interestingly they were not, which I was which I found very interesting.
Yeah, I mean, so yeah, let's take do you want to talk, we can talk about sort of survivor first and then talk about the graft and how the organ did. So the survival in general was, the mortality rate was high in this cohort. We just move my notes here. So we looked at both your graft failure, your loss of your graft, and your survival, and the mortality rate again. So at 3 and 5 years, when we look at the entire cohort, was 38.6% at 3 years and 31.4% at 5 years. So just under a third of the cohort was still alive 5 years later. When you think about those numbers, again, it's hard to put them in context because of the allo-auto, so we separated them. And as expected, the allogeneic cohort had a lower survival. So the 5-year cohort, the 5-year survival in the allogeneic recipients was 21.6%. We then looked by solid organ type, like what kind of type of transplant did you get? And there wasn't a statistically significant difference, but there appeared to be a difference in that the kidney solid organ transplant recipients had a 3-year overall survival of 17%. And that was in contrast to the thoracic solid organ transplant recipients that had 37.5 and then the liver 40.2. So none of them great, but the renal solid organ transplants really had the lowest survival. And we noticed that that survival dropped up even out at 5 years, that it became even lower. Among the autos, the survival was a little bit better, and there was a statistically significant difference in the survival by the transplant type. So the highest survival was in the thoracic recipient groups, and that was a 3-year survival of 58% compared to 30% in the renal solid organ transplants and 41% in the liver. We looked at some risk factors for death and how did they die. So in terms of risk factors for death, they had some shared risk factors for losing the graft, which we'll talk about next, but transplant indication, so any indication other than a plasma cell disorder, so leukemias, lymphomas, immune non-malignant conditions, they all had higher risks of death than the plasma cell disorders. Allogeneic versus autologous had a higher risk of death. And then in terms of organ transplant type, thoracic solid organ transplant recipients had the lower risk of death. They tended to do better, as the sort of incidences that we just discussed suggested. We were really curious about what did they die from, right? Was there more infection? Was there more organ dysfunction? And curiously, it seemed to be very consistent with the transplant cohort that did not have a previous solid organ. So much of the death was related to relapse of their primary cancer. There was about 15% that died of organ failure, but that's pretty in line with patients, again, who haven't had an organ transplant. And then about 15-ish% of infection, again, relatively in line with what other patients who haven't had a solid organ transplant. So I was surprised by the organ dysfunction. I thought, and failure, I thought we might see more there. I think the infection piece was not so surprising to me. I know that you get that the solid organ transplant patients are under immune suppression and maybe for a long, long time, low levels, but we also bring people to transplant who are heavily, heavily pretreated, many, many cycles of chemotherapy. They've been neutropenic for a very long time. So I think that there is differences in infection risk, and that's something we worry about in all transplant recipients. But that was the mortality data. And again, wasn't so surprising to me, the percentage and the higher risk of mortality. I was really surprised though by the percentage of graft loss in this study, which is higher than previous studies. So the graft loss, when you look at just all organ types at 3 years, was just under 60%. And at 5 years was 66%. And graft loss in this study was defined as needing another transplant or that organ failed. So that was pretty high to me. When we looked by organ type, again, we didn't find a statistically significant difference in graft loss by organ type, but it appeared to be quite different. It may be a sample size issue. At 5 years, thoracic graft loss incidence was 46%, liver solid organ transplant loss was 62%, and kidney was 80%. So the renal solid organ transplants really seemed to do poorly, more graft loss and more death. And it's not clear why these patients lost their graft. We don't have, there's a lot of missingness in the data set, so we don't really know why that happened. We did look at risk factors for graft loss of the organ, and there are many that were shared with risk factors for death. So the transplant indication, leukemia, lymphomas, allo versus auto, and then again, that thoracic solid organ, they had a lower risk of graft loss. So those were the outcomes of this cohort.
I guess the one question is the graft loss. Is that death-censored graft loss, or is it overall graft loss, which includes a death as a event?
So death was treated as a competing risk in this analysis. So not a composite endpoint. Yeah.
And although you don't have the granular data, what do you hypothesize as the reason why there's differences between the different organ transplants for the death and graft loss?
Yeah, so I think it's probably multifactorial. So one, there were more autologous recipients in the thoracic group, and we know that autologous recipients do better. So I think that that's a part of it. When we thought carefully about the renal issues, calcineurin inhibitors, which is what many of these patients are on for many, many years, certainly predispose you to renal injury. And then we give additional agents that can cause renal injury. So I wondered how much potentially was just cumulative and damage to the kidney, how much that contributed. Relapse was a major driver of death, and a kidney injury goes into our one of many things as we're thinking about prior to transplant, how strong of the drugs we give you. So do we give you really, really strong chemotherapy plus or minus radiation? If you have not great organ function, maybe you can't tolerate that and you're more likely to die from that. So maybe we reduce the intensity. And so I wondered if perhaps if someone had renal insufficiency or we were worried about the kidneys, maybe those patients got reduced intensity and maybe that could have increased their risk of relapse, perhaps. I think that we don't know, but those were just some of the ideas and hypotheses that we drew up.
Yeah, and I'll just add one thing, Michelle. I think I agree with everything that you said. When we see patients who have solid organ who present with a malignancy, lymphoma, leukemia, things like that, transplant centers are very quick to reduce the immunosuppression. So rejection is also on the table, and that can also compound what injury the graft experiences when they do get their conditioning regimens.
Yeah, great point, Meera.
I would have thought the rejection risk is higher in the thoracics, but you do say that's more autologous. So is it more, just so, because I'm not a hematologist, right? The autologous, is that more for the plasma cell malignancies, and then the leukemias, et cetera, get the allos?
Yeah, in this data set, which did include pediatrics and adults, I don't think I mentioned that specifically, but the median age was like 50. They're mostly adults. Adults in general get autologous transplants for plasma cell, exactly. And the leukemias and lymphomas are typically treated with allos instead.
Okay. And one more question on this particular pathway. You've got a solid organ first. We do reduce immune suppression, but we often keep them on a CNI. And so for your graft versus host disease risk, do you change or the targets or how we treat it, or do you just keep the same CNI and watch it?
It's a great question. So I don't think that there's a universal approach. I think that your question, though, becomes really key in my mind when I think about what could we do differently going forward, right? So a calcineurin inhibitor is the backbone of many of our approaches to prevent graft versus host disease. But there are things that are newer now, and there are different approaches. And so we can continue the same calcineurin inhibitor or something along that family, or now we can even think about approaches to try to spare the use of that. If we have a renal transplant recipient, I think it's ways that we can think about going forward, how might we make outcomes better for patients?
Now, slightly off topic again, because I'm interested, I'm not a hematologist, but I have been told by a hematology boss in the past that a little bit of graft versus host disease is a good thing to prevent the recurrence of disease. Is that true? And how does that play into how you target with your CNIs?
Yes, so we think about this double-edged sword. So on one edge of the sword is terrible graft versus host disease, which can be life-threatening and highly morbid. And the other edge of the sword in patients with malignancy, and particularly AML, so myeloid leukemias, there is this element of the immune system recognizing and killing the leukemia, so the anti-leukemia effect. So we're always wanting to do this GVL, graft versus leukemia, this GVHD, graft versus host disease, this scale. What I tell my patients when I consent them is, if I could control everything and you had terrible AML, I would give you just a little bit of GVHD. But we are not that good is the truth. And we don't have quite as much control. And so our approaches are in general to try to avoid this problem. About half of patients will get GVHD. If you just look at all comers, there's some additional risk factors, HLA matching, et cetera. But so it does still happen in a fair number of our patients, but I don't usually decrease the immune suppression to try to get a little bit of GVHD, because I'm too afraid that it will cause too much GVHD.
Great, thank you. I might move on to the next paper, where people with a stem cell transplant undergo solid organ transplant. Meera, can you tell us a bit more about this study and how you approach this?
Yes, of course. So this also parallels the other study, and we merged the data and extracted the cohort very similarly, with the exception of the hematopoietic cell transplant happening prior to a solid organ. So we're profiling patients who are ill with organ dysfunction after a hematopoietic cell transplant. And we found very similar characteristics that Michelle had mentioned, only in a little bit of different proportions. So, and maybe this is a patient selection thing, because they did go on to solid organ, but most of the patients in this cohort were middle-aged. The youngest, the interquartile range went as far down as the 20s. Had a hematopoietic cell transplant for malignancy, lymphoma, leukemia, and most of them underwent myoablative conditioning. Like Michelle said, with the other cohort, it was about 50-50 for allo-auto. This cohort also 55% received allogeneic HCT, or hematopoietic cell transplant, first. One thing that Michelle had mentioned when it comes to scoring systems and calculators was how frail or how functional or how healthy these patients are. And we had that in the CIBMTR data set. We had Karnofsky scores. We have this comorbidity index, which I thought was wonderful. And patients had high Karnofsky scores at their hematopoietic cell transplant. But one thing that we also noticed was that their comorbidity index was slightly higher. And when you look at the granular data as to the causes of their comorbidity index going up, some of it hinted to signs for end organ dysfunctions. Patients with diabetes, sometimes some of them were on temporary dialysis. So it kind of hinted to perhaps maybe these patients were at risk for developing organ disease later. And then finally, the majority of patients, around 80% of them, were on treatment for acute or chronic graft versus host disease prior to receiving an organ transplant, whether it was continuous or not. So to her point, with these patients getting hematopoietic cell transplants, the prophylaxis for graft versus host disease and the effects of the treatment and their malignancies may affect the organs later and lead them to need a solid organ. Now, I mentioned patient selection because, those patients who underwent solid organ transplant were probably the healthiest of the patients who had a prior hematologic malignancy and got a hematopoietic cell transplant. But I'll also mention that there was a cohort we identified, about 73 patients, who were listed for solid organ transplant, but did not receive one. So almost the same number of patients in our cohort of 80 who went on to get a solid organ did not. And that's also a limitation. We don't know the granular data for them in the UNOS data set, but I found it to be very interesting. So this is a selected group of patients. When we talk about the indications for solid organ, a little over 60% of this cohort underwent kidney transplant. So kidney transplant's the most common. But then a third underwent lung transplant. So it's a little bit more than the other cohort. And a very small handful, about 5 patients, underwent a liver transplant. So it's largely kidney and lung. And then of the kidney transplants, a little over half underwent a living donor kidney transplant. So you have that as well with the degree of matching, and the quality of the organ that they get when they get a living donor kidney transplant is far better than a deceased donor organ. Yet the outcomes are a little bit different compared to our general solid organ transplant population. Indications for solid organ did include graft versus host disease, as it was one of the most common. Bronchiolitis obliterans syndrome for lung, which is also strongly associated with graft versus host. And then hematologic malignancies such as lymphoma, myeloma. And then finally, in the kidney realm, we noticed a lot of patients with conditions that we consider as recurrent. So FSGS, lupus, hemolytic uremic syndrome, those can recur in a transplanted kidney. And so when I see that in a chimeric patient who has these autoimmune etiologies of their kidney disease, we think about the immunologic profile of them as well, and how that may impact their care and their outcomes. I can go on to talk about their outcomes if you'd like.
Yeah.
So very similar to the other paper. The differences in outcomes also depended on organ type. These are, we're comparing apples to oranges. The organ types are very different in terms of their immunotolerance. You know, the liver is way more tolerant to transplant than a kidney. You don't have to do cross match for liver. You just get a blood type and you go, which is very interesting. But organ type, allo versus auto, the allos also did slightly worse, and the presence of lymphoma. For outcomes of for death and graft loss, these were by and large the most common causes. Now, I think Dr. Anjan mentioned infection. One of the reasons for graft loss in this cohort was also CMV at the time of solid organ transplant. So their CMV status, which we thought was interesting because it wasn't part of the other cohort, but CMV serostatus at the time of solid organ transplant was, you know, a significant factor. Although, you know, just keep in mind that this is a small cohort. So some similarities, but then also some differences. When it comes to overall outcomes, the kidney cohort did better after a solid organ transplant following a hematopoietic cell transplant. In terms of survival, there was no difference in survival post-kidney transplant when compared to the general population of solid organ transplant. So that was actually positive. Although long term, the risk of graft loss after a kidney transplant was about 4 times higher than the general population. So that's to be taken with a grain of salt. And what Michelle had mentioned with potentially, you know, recurrence of disease, retreating for recurrent malignancy in these kidney patients, perhaps we need to do a little bit more work and look for alternatives for their treatments and conditioning. But I also found that to be very interesting. Also very interesting in our lung cohort, the outcomes were very comparable. In fact, we found some papers of lung transplant after hematopoietic cell transplant, and our results showed more favorable results for lung transplantation in terms of survival. So There's something to be said about how we approach these patients, and that they're not all in the same um, uh, category when we consider risk and fear, if you will, when we see them and try to figure out their immune profile and how best to take care of them. So those are just some of the things that we um, identified in this paper.
Great, thank you. Just a sidetrack for the audience there, if you have any questions, please post in the Q&A box. Now, Meera, like you said, this is a highly select group. They have to have a lot of things lined up before they're listed for solid organ transplant. How long do they have to wait after the hematopoietic cell transplant, like in terms of remission or how stable they are? Because it's quite a rocky course.
It is, and it's not standard. So, for example, when we see, and this is anecdotal, when we see a patient with a prior hematopoietic cell transplant, we request records, we reach out to their hematologist, we get a sense of what their current status is and what their risk is, and they're extremely helpful. Some centers will create arbitrary remissions of 1 to 2 years. Some centers will rely heavily on repeating labs and checking to see if they have any signs of recurrence. But it's not standard, and it's not commonplace for people to get together and talk about putting people in categories, if you will, because every patient is different, and not all patients who undergo hematopoietic cell transplant for whatever indication behave the same way. Um, so we rely heavily on their hematologists to tell us when it's safe and how best to take care of them afterwards. Now, the tricky part with solid organ transplant is you don't know when it's going to happen unless someone gets a living donor kidney because someone comes forward and says, I want to donate my kidney to this person, and then you test them and you schedule a surgery date. We list them on the list and we wait. The average waiting time for a deceased donor kidney transplant in this country is about 5 years. So it's hard to know. And one can imagine that if you have a patient with a prior hematopoietic cell transplant that's waiting for a kidney, they may become ineligible if they wait too long and they have other comorbidities or they have recurrence and then they're removed from the waiting list. So that's unfortunate. And if there's any opportunities from our work here is to come up with strategies and guidelines eventually to help inform practice so that we can help these patients because their outcomes, especially for kidney, are not too bad and acceptable for the things that they face if they don't get one.
Thanks, Meera. You had mentioned patient selection, and I was really curious because from what I understand, I think if you have a hematopoietic cell transplant and you're being listed for a solid organ transplant, you can make a case that they're relatively, not absolutely, relatively stable enough to undergo a solid organ transplant. But then the reverse is not true because most of the people who had a solid organ transplant getting a hematopoietic transplant actually had malignancy. So, in my mind, that would make them a lot more sicker than this cohort. And do you think that had any influence in the outcomes that you saw in these two different papers?
Um, well, I mean, I don't want to take the stage. I think Michelle has a lot of experience too. For patients who have had solid organ, and end up developing a malignancy and then need a hematopoietic cell transplant, there's um, a lot of factors that come into play with how to manage them because not only do you want to preserve their solid organ and not remove the immunosuppression and allow them to reject with organ dysfunction, but you also want to treat their cancer. And then you're faced with, do I take care of the patient or do I take care of the organ? And with kidney, it's a little bit easier to say, you know what, let's take care of the patient because we have dialysis. In liver, it's a lot harder. And in lung, it's a lot harder. And when the organ fails, the patient dies by and large. For statistically, that's what we see in the data. Um, so it's different for every organ type. And I think what we see in the post-solid organ data after they've had a prior hematopoietic cell transplant and the kidney's not doing well, it's probably because the team had to make a choice to either take care of the patient and allow the organ to fail when it comes to the treatment. And that's just a side effect of taking care of the patient. That's sort of my personal opinion. But I think Michelle can comment on that too.
Yeah, I remember when Meera and I were looking over this data, how horrified she was when we looked at the survival data. And Rachel and I were like, not too bad. I mean, I think that what's happening here is there's some bias, right? So cancer is often bad. If you're getting a bone marrow transplant for cancer, you usually have pretty bad cancer. And so if one study took this group of patients that had pretty bad cancer, largely, went through transplant, which is not always, it has a lot of complications, right? And then they had the solid organ transplant before, but we put them through this taxing process, and then many of them had their cancer come back. So I think they did relatively poorly, but so do the general population without a solid organ transplant. The other study is almost in many ways biased, right? So these are patients that probably had pretty bad cancer. They underwent a transplant, and then you have to survive the transplant to still have organ dysfunction later, right? And as Meera said, you usually don't transplant them until they're so many years post-transplant. So there have been people that have died from their transplant, people that have died from their malignancy, and all of those are really filtered out. You're only seeing the best players, the ones who survive their transplant, don't have cancer, and then they have organ dysfunction and make it. So I interpret this study as, if you've had these two studies, if you'd have a bone marrow transplant before, and you're coming in with organ dysfunction, and you need a solid organ transplant, you're probably going to do about the same as the regular population, right? Because you've been filtered out, you've survived your transplant, you don't have cancer, so you're probably going to do pretty well. The other way, if you come in with a solid organ transplant and you're going through the challenging taxing process of a transplant, you have additional risks. And those risks include graft failure, and they include death. And does that mean, in my opinion, that you're not a bone marrow transplant candidate? I don't think so. If you have terrible cancer and you need a bone marrow transplant to be cured, we should think about that. I just think we have to think about how to mitigate risk for the graft and for death, and how to make things better for people going forward.
Fantastic explanation of that. Thank you, Michelle. Myeloma is always a problem for transplantation, particularly for kidney, because in the KDIGO guideline, it says you cannot transplant unless it's cured or in really, really stable remission. What would you say about that, Michelle? How good is the data now with all the changing and moving bits and treatment options?
So my disclosure is that I'm a pediatrician and I don't take care of myeloma.
Yes.
But the multiple myeloma field is drastically changing and transforming. There are several new drugs. There's CAR-T now that have completely changed the game for multiple myeloma. So this was a disease that I think many people would get transplanted for and then subsequently die. And now things are completely different. The outcomes are so much better with these novel agents. But again, I am a pediatrician.
Were there many myeloma patients that had a bone marrow and then went on to solid organ in your cohort?
Yes. So I'll speak to that. It was one of the more common indications, I would say. And the outcomes were not too bad. I think, speaking to what Michelle had said, we have a lot of patients who have myeloma, and they develop myeloma kidney disease as well. When we approach them and get them listed, they are still under surveillance by their hematologist. We follow their kappa lambda light chains and make sure that if they have any risk factors for recurrence, that they're treated, and then we pause and then we treat them. But that is not a contraindication for transplant. There are a lot of patients with smoldering myeloma, and we're okay with that now. And I think that while people consider that a malignancy, I think the population now is sort of steering away from it because it's one of those diseases that's better controlled, if you will.
Thank you. Anyway, so there's no questions from the audience at the moment. I guess if I ask all of you guys in terms of counseling your patients, so they come to you and say, should I really get a kidney transplant or should I get a solid organ transplant? I've gone through bone marrow and survived. Is it worth the risk?
Yeah, I'll let Meera, because you
Muted.
said bone marrow transplant
I
first.
was
Meera, you
muted.
can answer this one, and then I'll take the
Oh, sure.
Reverse. Yeah.
So when we talk to patients, when we see patients with a prior hematopoietic cell transplant, we highlight the obvious fact that they are unique with different challenges compared to the general population. We do a teaching session with all of our potential recipients, and I basically tell them to throw all the data out the window because it doesn't apply to them. And because of that, they need to understand that we don't know what we don't know yet, but we're starting to know. And now we have real data to inform patients. But what I say is, yes, it's possible to transplant you, but some known risks are associated with overall and graft survival, and that depends on several factors. And those are the ones we mentioned, if you have lymphoma, if you have a history of CMV at the time of solid organ, et cetera, which are things that we know now that we can keep an eye on and follow. And then we also have to acknowledge that while this data is important, our current cohort is not very large. So understanding these risks requires ongoing study to confirm or modify our guidance and then our counseling to patients.
Yeah, I think you're spot on, Meera. When I think about how I counsel patients with this data, it's important to recognize the limitations. So the sample size, while the largest for sure of this type of cohort, is still relatively limited. That precluded multivariable analyses. There's some missingness that we talked about that's really important. And then I, just from a transplant perspective, will highlight that the first patient entered this study in 1989. And bone marrow transplant looks very different today in 2025 than it did then. And so we really have gotten much better at supportive care. The non-relapse related mortality is much better. We have some very novel new things. You're talking about CMV. We have good medication for that now that we didn't have 10 years ago. We have new ways to safely transplant mismatched donors. So I do think that it's a whole new world. And when I counsel patients, I just had a patient who had a kidney transplant. I'd come for a BMT consult and said, these are the data that we have, but I think it's probably better, right? Non-relapse related mortality is better for the patients who didn't get a solid organ transplant. It's probably better for you too. How much better? I don't know. Now relapse rates are unchanged, and relapse is a problem. We saw that in this data. And so how do we approach the disease, your underlying disease, the best that we can, try to preserve your graft function, and just making sure that you know the risks that are likely higher proceeding.
Fantastic.
Okay.
One last question from me, I guess. Again, slightly off topic, but someone mentioned TMA earlier on. I think it was Meera. After bone marrow transplant, and they've got a TMA. What do you test to look at genetic risk? Do you test I guess the blood would have the donor. Do you test a bit of tissue for the recipient, or what do you do?
Well, we don't really know yet. It's definitely not universal. The TMA that happens after bone marrow transplant is slightly different than the TMA that can happen in atypical HUS that we know is primarily driven by dysregulated complement, and it doesn't have anything to do with ADAMTS13 like TTP. Complement is probably important in some patients, is probably important in many patients. We think that endothelial damage from the many different things that we do to them is also contributing. You can test the genetics. So most complement is generated from the liver. So that would be the recipient's complement genetic testing. There have been some studies that have looked at the donor's complement variation. Again, that really, like donor lymphocytes, produce very, very little complement. So I would be surprised that that's a driver. But most of the studies look at variants of unknown significance and not pathogenic variants. It's very, very unclear. So when we find someone, they're typically diagnosed clinically, if we get an organ biopsy like a kidney, right now there's actually no evidence to suggest that like complement deposition is different in TA-TMA. That studies, those haven't been done. So they're just diagnosed under the microscope looking like any other TMA. And there's no FDA-approved therapies for TMA in the transplant setting. So people will do non-FDA-approved therapies, but for other indications. So certainly there's complement inhibition that has been tried with mixed results. There's defibrotide, other vascular stabilizing approaches, but it's definitely not universal, and it definitely causes lots of renal failure, so need later transplants. Those are, I think, a big driver of morbidity in transplant.
Well, that also answers part of the next question was with TA-associated TMA, how long do you go with treatment with the complement inhibitors, etc.? But it sounds like it's an area that needs more work, doesn't it?
Yes, this is not like atypical HUS. So when people use complement inhibition, it's typically a very intense but brief course. So you're not on forever. And then some people will have kidney recovery, some don't. But most places stop the medicine, whether you recover or not in your kidneys. And if you don't recover, then we can potentially talk about transplant.
Great, thank you so much. Any questions from Shweta or any other panelists to each other, I guess?
Yeah, I was gonna wait for the audience. But in the meantime, I know, I guess Meera and Michelle and Rachel, you all said this is just the beginning of, research into this field, and the first patient was actually in 1989. A lot of things have changed since then. So what do you think is next for research in this particular population, and what questions would have the most value, you think?
Well, I think about this a lot. We actually merged the data sets twice over the course of the years that we were trying to study this to see if we could capture more patients. In doing this, UNOS has created a variable that will allow us to remerge at a later date if we choose to do so. So hopefully it'll be a lot easier to be able to redo the study and then hone in on some more specifics. I think the things that we will continue to not have are those that are intangible or the granular data, because of the very fact that this is a large data registry without all of the small details and the readmissions and all of the biopsies and what's actually happening on a day-to-day basis with these patients. But knowing what we know now, we can hone in on the specific things, the lymphoma, the GVHD, the CMV, the calcineurin inhibitor use, etc. So we can use those things to further delve into those, and then hopefully with a larger group of patients. And then hopefully over time, we can start to gather that granular data that we're hoping to get to further inform practice.
I've seen at several conferences this from a renal transplant perspective, doing from a living donor a bone marrow transplant at the same time when you don't have cancer, so that you can get off of CNI. So I think that that's interesting, and I'm interested to see where that field goes. But yeah.
Well, we purposely did not include patients who had a bone marrow and a solid organ at the same time. Although it would be hard to tell, I think the shortest interval between transplants, at least for the hematopoietic to solid organ cohort, was about 3 months. But who knows? There's a lot of exciting things happening with the immune cells, and there's a few studies that we're involved with where the recipient undergoes plasma exchange, and they extract the T cells and treat them, and then at the time of transplant reinfuse the T cells, the regulatory T cells, to try to reduce immunosuppression needs. And so that's also very exciting, where you can actually use the recipient's own cells and condition them such that the immune system is more tolerant.
Yeah, I think we all kind of learned, about things that we were missing that we already mentioned in this study that we wish that we had, right? So if we do this again in a more contemporary cohort, we could plan ahead for that to get some of that data, which would make it more robust. And I think it would be interesting just to see how things shake out again in the contemporary era. So in transplant, for instance, we're doing more and more haplo-identical transplants. So we actually use family members as the stem cell source. And so are we going to see more family members that are living donors, right? Related living solid organ donors, right? We might see that become a more common practice. We also are transplanting many older patients. So whereas we used to look at a patient who is 60 and above and be like, oh, you're not really a candidate. If you look at our numbers in the CIBMTR database, we're transplanting more and more patients that are over 60, over 70, right? And so those patients also have, cumulative damage to their organs. And so are we going to be offering more solid organ transplants to them? Like where's our limit here, right? So I think it'll be really interesting to see how things have changed over time. And for treatment of cancer, we do have a lot of novel targeted agents. So hopefully these patients will come in with less damage to their underlying organs and then, less need for solid organ transplant, or if they have to undergo one or the other transplant, they'll have better outcomes. So I think it definitely is a study that should be done again at some point when we look at the more recent transplant practices. And like Michelle and Meera both said, I think we are likely to see better outcomes, although we can't put numbers on that for our patients right now.
100% agree. Thank you for that. Time is up. But thank you so much to Shweta, Michelle, Meera, and Rachel for tuning in and giving all your expert insights. Thank you to the audience for attending, and please complete the evaluation form before you finish and log off from this. Thank you, everybody, and hopefully we'll hear and see more data come from in this particular area soon.